Okay, so this is just a warm-up. It's not the beginning of the session yet, but let's have an insight. So we had a 55 years old lady who had a history of sagittal vein thrombosis in the past on warfarin, normal coronaries. There was this discussion about achalasia, issues with gastro, which has been treated out. And she's been having dilated cardiomyopathy, impaired ejection fraction with repeated heart failure presentation, and her blood work showing a high WBC despite there is no source of infection, and she was under workup with hematology. Renal impairment in the back, and also some electrolyte imbalance. So this is her transesophageal echo. So Dr. Zakaria, you can comment on the imaging if you don't mind.
So you can see it's a significant mitral regurgitation, but also you can see the LV is dilated and moderately reduced ejection fraction. The LA is a bit smallish, which is not expected, but and now you can see that there are multiple jets of mitral regurgitation. And here it is mainly central to, and there is another jet, medial jet of MR. So the annulus is dilated, the mitral annulus is a bit dilated. So it goes with functional mitral regurgitation. For more? Yeah, so this is the posterior mitral valve leaflet.
Just like around 10. This is your 3D?
Yeah, this is the 3D. And if you go, you see that in A2, this prolapse segment, relative prolapse segment, and then the posterior mitral valve leaflet, there is a fold. Maybe it's a fold, a cleft, or a deep indentation. But the gain is a bit the gain is low, so maybe we are missing some tissue. But
so
you
the
can
area,
see the area, the mitral valve area is 4.5. Yeah.
So, what do you think? We can start around the table from Dr. Rashida. What do you think?
Well, she's 55 years old. She's young. I know she had non-ischemic cardiomyopathy with ejection fraction 30%. I still believe that her anatomy is complex. There is multiple jets. There might be a cleft on the mitral leaflet. So I will consider this patient for mitral valve repair versus a surgical replacement. After assess her clinically, like see how the frailty and other risk factors.
Okay, Dr. Anas?
Non-ischemic cardiomyopathy, very kind of wide annulus with loss of coaptation length, restricted posterior leaflet, anterior leaflet override. I would really investigate that dropout in the posterior leaflet. My trick is to usually look at 3D from both sides, just to make sure that we don't see, this is not like a true cleft, that it's more like an indentation. My other trick is to use my biplane imaging, just to make sure that all of the jet is actually originating from the actual coaptation line. Once that is ensured, and I'm comfortable that the patient is on maximal medical and device therapy, I think it's reasonable to attempt TEER in this patient.
Dr. Hajji, Dr. Mahmoud, any thoughts, both of you?
Yeah, I think the images are a little bit challenging. The 2D showed a wide jet, medial lateral as well. But on your 3D, you showed potential position of a cleft in the middle of the valve. So if this is a true cleft, then will make mitral TEER a little bit challenging. But you can address that by, if the patient will go for mitral clip, by aligning the mitral clip a little bit, not 12 to 6, just to try to close or reduce the cleft gap.
Dr. Traina?
Yeah, I think it's the same, I think this is, ideally surgical if for a younger patient, but I think given the complex repair, it's going to be a challenge, and the reduced DF, I think that's probably what drove your decision to do this. I echo everyone's, the cleft is going to be the important issue because you may open that up And so you may end up causing worse MR from that location. I think it's a pseudo. I don't think it's a real cleft. So I think you'll probably be okay, but that would be before I attacked it, I would look into that a little more.
Dr. Ahmed.
So I agree with Dr. Trainer that the first thing we need to confirm is it true or pseudo cleft. We do both sides 3D, but actually 3D sometimes you have dropout. So what I would do, I'd do screening from lateral to medial, even by 2D, by going backward and forward, or also do MPRs. If you have in your machine MPRs, would actually allow you to move throughout the valve. Then you will see actually, if the 2D echo leaflet drops actually become black on your echo when you screen the leaflet, then you know it's actually going to be challenging.
So-
But that's the first question, that to get a proper decision about the true or pseudo.
Okay. So as we can see, we had two agreeing with surgery, but the rest said we want to do a trial tier. So tier 1 in this case. I will just go quickly through this, but as you can see, we have attempted a transseptal puncture, and you can see when we tried with a mechanical puncture here, the needle didn't go at all, okay? And our surgeon weren't very happy with the WBC of 22 issues of thromboembolic events in the past, so, and history of achalasia or difficult GI situation, so they weren't like enthusiastic to take her into the table. And when we were doing the transseptal, like it just didn't go, despite many attempts. So we shifted to a transseptal puncture with a radio frequency, and we crossed very easily in less than 1 minute. And usually in my practice, I give some heparin, and at that ACT at this stage was 250. So here you can see the guide is going very nicely through, but in a second, our imager started to point out that there is something going on your guide. So the question was to wait or go with the wire. We pump up the ACT, and we put the wire, and the things is not getting great. You can see the thrombus on the wire here, okay? And what did we do? We pushed the wire, a catheter, we aspirated, we ballooned, because we have even difficulty crossing with an 8.5 guide through that transseptal. The ACT was 400 at that stage, okay? We ballooned, and we crossed with the guide. We thought, okay, maybe it was a tissue because of the struggle that we had with the transseptal. And that's what happened. We pulled whatever was going on in the right to the left now. So this is what we are seeing now here. So there was like a pause of 45 minutes or a 1 hour discussion. What should we do? Should we proceed with a tier or not? And this is where we were discussing that the WBC in the beginning was 22,000 and history of thromboembolic event of a sagittal vein thrombosis. Later on, after 3 weeks, the patient came up to be some sort of genetic mutation that had predisposed to a myeloproliferative disorder that is more susceptible to do this. So looking now at this, maybe if you took the patient surgically, maybe you will have had suffered, despite the ACT was 400, 450, still thrombus were happening. We brought an intervention radiology with us neurology, and we had the discussion, should we proceed or not? He was in the room with his equipment, and we decided we will proceed with TEER, and then if something happened, he's gonna just pull up the thrombus if something fall out. I tried to do a sentinel device, a protection, but unfortunately, as we know, things doesn't go well. It will not go well throughout the case. It was occluded here, basically radial. So we proceeded with the TEER. It wasn't a challenging TEER at all, as you can see. Like, we went with a sandwich maneuver, like having a clip from each side. And as I said, like, we have some reduction here, we optimize it. The gradient was 4, and this is where we discussed, like, you know, our area was 4.5. We have still some jet on the lateral side, and we put another device there. But as we were moving medial and lateral, we noticed that finally, it's just now became it's in the left system, our thrombus. So we said, we are there, nevertheless, let's put the second clip. And as I said, we went with a sandwich maneuver to clip both arms and to cinch this cleft. We put the device here, and you can see the thrombus still on the right side, nothing on the left side. Our gradient was ranging between 6 and 7. We accepted it, and while we were pulling it, the whole thing went out. So patient did well afterward. There was like a intensifying of the heparin and the anticoagulation. Though she is on warfarin, we didn't stop the warfarin. We heparinized prior to the transeptal, but we encountered what we encountered. The moral of this, just like if you have a case like that, just be careful in terms of like, if there's a hematological disorder, don't stop the heparin. Keep it INR in high as possible, 2 to 3. In addition to that, there is some reports like with radiofrequency transeptal puncture, there is a more susceptibility to have thrombus, so keep an eye on that. And if you encounter something like that, maybe a better solution is to close this ASD, because if she had the right-sided thrombus in the future, it might just fly to the brain. Thank you.